Hi, everybody. Thank you for joining. Thanks for listening to our IT problems. So this didactic that we're on is Emergency Medicine COVID Pandemic Experience Insights from the New York City Epicenter, and this is a panel presentation. Next slide, please. So I'm just going to talk about the diversity of panelists that we have from the New York City area. So my name is Nancy Kwan. I'm one of the moderators. I'm the Vice Chair of Emergency Medicine, Long Island Jewish Medical Center. We also have Eric Cruzen, who's the Chief Medical Information Officer from the Emergency Medicine Service Line at Northwell Health. We have Dr. Christopher Caspers, who's the Vice Chair of Education from the Department of Emergency Medicine at NYU Langone Medical Center. Dr. Eric Lagome, who's the chair of emergency medicine at Mount Sinai West and Morningside Hospitals in the Mount Sinai Hospital System. Dr. Marie Romney, who's the vice president of operations from the New York Presbyterian Hospital Center. And Dr. Annabella Salvador Kelly, who's the associate chief medical officer and senior vice president of medical affairs from Northwell Health. And last but not least, Dr. Manish Sharma, who hopefully will be entering this talk shortly, who's the chair of the Department of Emergency Medicine at New York Presbyterian Hospital, Queens. So just a little bit of how this didactic will go. There's going to be 3 areas that we're going to cover: clinical guidelines regarding COVID-19. That's going to be Drs. Lagome and Caspers. Load balancing and lessons learned. That's Drs. Salvador Kelly and Cruzen. And the psychological impact, resilience, and wellness. That's Drs. Romney and Sharma. And then we'll have a Q&A session afterwards. So, not to go into detail about, what happened during COVID. I think everybody who's on this is pretty well aware, but in the New York City area, the first confirmed case was in Manhattan of somebody who returned from a trip, and that was on March 1st. And then, as you know, things progressed very rapidly. Luckily in 2020, we were able to get the first person in the country vaccinated. And as you know, vaccination in 2021 has really spread immensely as we are coming out of the second wave. Next slide, please. So I'm going to hand it over to Drs. Caspers and Lagome.
Thanks, Nancy. Thank you all for coming. I have to say that I thought the operational difficulties of COVID were, there's nothing I've seen like that until I got to here 15 minutes ago to get everyone on. So thank you all for your patience. I appreciate it. I'm going to talk a little bit about a little of the clinical guidelines and how we integrated them and why we integrated them and why I think they're so important. So you've all seen slides like this. I've seen, I think, about 15 since I've been at SAM for the last few days. But this gives you a sense of the New York City area. This is the Mount Sinai system. And I think that if we asked the New York Press system, the Northwell system, they all look kind of similar. But if you look on 315, we had, or 313, we had about 59 patients across our system in one of our 6 hospitals. And if you look on 327, we had 1,000 admitted patients in the hospital system, and we peaked at a little over 1,600 on 416. So within about a month, we went from very few to over probably close to half the beds in the system and more than half the beds in some of the hospitals filled with COVID patients. So it was a very, very rapid rise, and it was also a rapid rise in the setting of constantly changing information and really the inability in many cases to get a diagnosis, especially in the emergency department. On the bottom is just the 2 hospitals that I oversee, the emergency department. And if you look, we had admitted in the first wave close to 1,700 patients in those 2 hospitals. About 500, about 400 died during that time. The rest, most of them we have discharged, and we peaked with about 500 and some in the 2 hospitals as inpatients on a one specific day, which at one of the hospitals that was over 50% of the beds in there. Next slide, please. So one of the things I came to talk about is clinical protocols. And I would say that the clinical protocols were really immensely helpful. And in any sort of pandemic, I think, or any sort of response, developing them and putting them in place is incredibly useful. And just a little bit of a background, when I walked in the department, probably about the 5th day of this, where we had no protocols, I remember seeing attending admitting one of the patients, I said, why did you make the decision to admit that patient? He said, well, the ICU attending told me that anyone who has anything on an X-ray needs to be admitted to the hospital. And I thought, that I'm not sure that's true. I actually don't know the reality. And you know what? If we all start practicing like this, we're essentially going to be screwed very quickly. And so we sat down and said, how do we decrease our variability and make our ability to plan a little bit easier? So why do we use the protocol? So we talked about reducing variability. There is a ton of information out there, and there was a ton of information coming through the internet, through friends, through colleagues. For those of you who looked on and I watched the ASAP website, there was great information coming through there, but there's some crazy stuff also that people were putting on there. And how are you going to vet it? We needed to make sure that people were practicing appropriately. Just because it was a good idea somewhere else, it may not have been a real idea or appropriate idea. We wanted to provide consistent updates and provide expectations for other services of what we were going to do. The other thing to help with was resources and planning. As we started putting things together, and many of you use things like tents, we needed to know what were the protocols going to be across all our tents, because if we said that for everyone who was very low risk was going to get a chest x-ray, we needed a way to do chest x-rays there. If none of them were, or rarely were they, we could transfer them out, and we did not need that type of resource in there. So it really helped us with planning both our resources in the department and moving upstairs. Next slide, please. So we've actually published a couple of these. We published them in Emergency Medicine Practice. They were free for anyone who wanted to use them. But this is one iteration. It's been redone, and it's actually been done probably about 15 times. We keep updating, and we're updating it as of a few weeks ago. We just put the new updates on MOABs and how we're using them in the emergency department. So this is essentially the dictionary for our system. If there's any questions, what to do, where to look. Next slide, please. So for example, this is some of the early ones about radiographic testing, who should get it, who shouldn't get it. A current one near on the bottom one is if someone comes in from an outside hospital or an urgent care and has a test, who needs another test, who doesn't need another test, what can we use, what testing are we doing in the patient populations that come in, who needs test, who doesn't, if they're getting admitted, what do they need? And one of the things that was very helpful is as we put these together, we would use them for a week or two, and then we would integrate them into our electronic medical record. And most of you have Epic. It's not easy to get things into Epic, but during this time period, actually was relatively easy to make those changes. And so as we put new things in the guideline, we would put changes into Epic to kind of reinforce them and make them move that way. Next slide, please. Here's some stuff on the disposition and admission criteria that we use to help people, give them guidelines and who would get into just being sent home, who would get a pulse oximeter, et cetera. There's some, it's hard to see, but on the bottom, just give you a sense that was what to do with patients who were going to be under palliative care, what to do with end-of-life dyspnea, how to treat them. So things that would come up that people didn't do on a regular basis, we wanted to make sure they were in our guidelines so everyone would be on the same page. And also nursing would know what to expect to us, what we're going to be ordering, how to order it. Next page. And other things we did that were a little bit, I think, unique for us is some of the guidelines really we made up as time was going on because there wasn't anything out there. This was something we did about cohorting early on when it would take a day or so to get a test back. We had more patients that had COVID or likely had COVID in the emergency department than we were able to cohort. We couldn't keep them apart. And so at some point, what we did is we came up with what we thought were reasonable guidelines of who would be presumptively diagnosed with COVID. And we put those into our kind of local guidelines. We did end up, I think we presented this at SAM on another session, but we went back and looked at it after SAM, and we found that we were about 98 or 99% sensitive in coming up with, or specific, and we were able to pick out the patients who had COVID prior to having a test, which was actually very, very helpful. So in a high prevalence time, without a test being available, we were able to cohort them appropriately. Next slide. And while I'm not going to get into it and you can't read these because it's too small, this is just some of the information from just the emergency departments in New York City. These were all from ED providers, mostly in the Manhattan area, who published on COVID and a lot of the protocols that they put together. So a lot of really good stuff did come out of this, and hopefully will be helpful in future if we get to future pandemics. Chris?
Thank you, Eric. Can you hear me okay? All right, great. So just brought myself back in time with this slide and takes us where I circled in red back to the beginning of the wave, those first couple of days when things started accelerating really rapidly and how we all were trying to make sense of what was going on. So couldn't say it better. When it came to guidelines, it was the best way to organize the information at hand and just to get everybody on the same page with respect to care. Next slide, please. Again, looking back in time, things were closing down. When we went on lockdown in New York City and COVID was skyrocketing, I remember the day that the comfort came in and really just taking a step back now and looking at it. I can't believe how far we've come, especially in light of yesterday's announcements. Next slide. So we started with making guidelines. Our first initial efforts were focused on keeping patients out of the hospital. Patients that were coming into the ED and trying to preserve our scarce inpatient beds for only those that were the sickest. We started out by publishing standards with respect to pulse ox and trying to create guidelines on who needed to be admitted versus who could possibly be managed as an outpatient, settling on 92%, which is where we thought we would need to be initially. Next slide. But as things went on, we started to learn that the spread of the virus was challenging every aspect of healthcare delivery, and particularly hospital-based care. We saw shortages everywhere, like many did, in PPE, straining our patient care delivery in the hospitals. Those of us in the pandemic hotspots experienced very high acuity patient loads in the EDs, and eventually severe boarding as the hospitals struggled to manage patient placement and flow. Primary care offices closed, and also declined to see patients with respiratory symptoms for fear of infecting other patients, which compounded unmet patient needs. So to combat virus transmission and slow the spread, many states extensively implemented social distancing and stay-at-home orders. We focused our efforts subsequently on expanding telehealth, and virtual urgent care were prompted as solutions to deliver medical care while allowing for social distancing and helping decrease patient loads on the EDs. Our institution had operated virtual urgent care at that time since 2017. We had staffed it with ED attendants treating non-emergent patient complaints. During the COVID-19 pandemic surge in New York City to provide care for patients seeking care that didn't have access anywhere else, at a time when we were telling patients to do their best to stay out of the ED unless they absolutely needed to be there. Our virtual urgent care platform rapidly scaled to deliver services to hundreds of patients a day via the telehealth platform. So for example, the virtual urgent care typically saw about 6,000 patients annually, 15 to 20 patients a day. During the 1 month COVID surge in New York City, you can see we took care of about 18,000 patients in a 1 month period. So our daily volumes went from 25 a day to over 1,000 a day, which was a massive surge. On the bottom left, there is a geospatial map to show you where the patients were coming from. They came from all over the tri-state area. Patients didn't have any other way to expand to receive access. And I remember my first patient was up in I think a lockdown area in Yonkers. So it was a special way to get in touch with patients that were afraid to leave their houses or really couldn't. We expanded our virtual urgent care hours from 7 o'clock in the morning to 11 at night, eventually to a 24-hour model. We took care of patients that were in their 90s and above at 3 o'clock in the morning, staffing in an on-demand fashion. We brought on 251 physicians to provide this care and provided them their onboarding via teleconferences and any other way that we could train them. And at the peak of the study period, we were providing coverage with 62 providers a day, providing care in short spurts wherever they could, in between meetings, during shifts, after shifts, and at one point we provided 364 patient care hours in the 24 period. So how was it from the patient's perspective? We surveyed 2,700 patients. 81% reported that they would have sought care in person had the virtual urgent care option not been available. 19% said that they would not have sought care anywhere. So the overwhelming majority of the patients that we saw did have suspected COVID-19, but remember back then we weren't testing, so these were all clinical diagnoses. And with virtual on-demand services like we were providing, this was the only way to get care. So why guidelines? The guidelines became really important because when we look back at the outcomes for the patients that we were receiving, we realized that there was a pretty broad variability in how we were making decisions. And many of our providers were taking care of patients on telehealth for the first time in their careers. And so giving them guidelines provided them some guardrails to operate within. We started noticing that patients were actually dying after virtual urgent care encounters. For us, this was startling, going from a 24 patient a day, low acuity complaint type model to taking care of 800 plus patients a day and having deaths. Completely changed the landscape of what we were doing for telehealth. On top of that, we didn't have any lab or radiographic ability. So creating guidelines that didn't take into account vitals, diagnostic testing was a bit challenging as well. We didn't have any kind of dedicated follow-up. There were no consult services. And so with this high acuity patient population, we needed to give our providers some guidelines to refer patients into the hospital. We did that on April 7th. So on April 7th, patients aged 60 or older who had a fever, cough, GI complaints, or a discharge diagnosis of COVID-19 were identified. Patients that met these criteria, we called back within 36 to 48 hours with a provider. And we determined this just by going through charts of every patient that died after a virtual urgent care encounter that we thought had COVID and identifying the risk factors that we thought portended some kind of adverse outcome, particularly death. During that period that we looked back, there were 37 deaths after a virtual urgent care encounter. And by implementing these guidelines and then calling patients and seeing if they had any worsening of symptoms after 6 days, presence of dyspnea on ambulation or new neurologic symptoms, dizziness, falls, we referred every one of these patients to the ED, trying to be selective about who we referred in, but at the same time being sensitive enough not to put anybody at risk to stay home. After that intervention, for the rest of the first wave of COVID, we actually had 0 deaths with this process within 48 hours of a virtual urgent care encounter. And ultimately, we saw a 40% decrease in mortality overall with this enhanced follow-up. There were 2 deaths within 48 hours of a virtual urgent care visit in the after period, but both of those patients were referred to the ED. And we felt that this was an effective way to use guidelines in a very rapidly evolving landscape in uncharted territory as it related to telehealth and COVID-19 care. So it's important just to remember that when it comes to guidelines, when we're shifting from conventional care to crisis standards, there is a continuum, but recognizing where we are and how to mitigate any of those risks is important, and we need to do it as quickly as possible. And so in our example, we felt that this was an effective way to do so, and eventually ended up sharing this data with the Joint Commission. So hopefully this leads to good downstream care. Next up, Dr. Salvador Kelly and Dr. Cruzen. Next slide. Thank you.
Thank you very much, Chris. Well, I know you've seen graphs like this so many times that it probably is making your eyes bleed. So I thought, here's one more. And the reason that we wanted to show you this slide, this is the positivity rates in New York City, in the New York City area. We wanted to sort of reinforce how incredibly rapid the climb was in the first wave. And then sort of the lingering period where we were waiting all through the summer for the other shoe to drop and for the second wave to come. And no one knew, of course, what to expect from the second wave. Everyone was presuming the worst and thinking, oh my goodness, it'll be like the first one. We better get ready for this ridiculously steep uptick. But as you can see, happily, it was a much lower and slower curve. Go ahead and go to the next slide.
Great, thank you, Eric. And as you can see from the previous graph, wave 1 did not observe the normal distribution. And also it was very fast and furious. It focused really on the downstate area of New York, especially New York City, lower Westchester and Western Long Island. And, looking at this map is definitely bringing back some old memories since I was born and raised and live in New Rochelle, which was, and I live in the 1 mile lockdown area, which was the first lockdown area of New York. So this is really bringing back some emotions. But as you can see, there were these hot spots, and Northwell has 23 hospitals, 2 subacute nursing facilities, and 8 of our hospitals were really affected far worse than the other sites. Therefore, making staffing, bed capacity, equipment a real problem for us, and our infrastructure was beginning to fail. We needed to really act fast. And this is when we started thinking of this concept of load balancing, because it was so important for us. And we began to load balance everything. You name it, we were load balancing it. Equipment, medications, staffing, patients. So on March 7th of 2020, Governor Cuomo signed an executive order that essentially loosened the regulations around the hospitals as it pertained to discharges, transfers, and admissions. And this allowed us to move patients faster and a little bit easier than traditionally. The issue that we were having, though, was that normally some of these hospitals that were in the hot spots were our receiving hospitals. And now they had to flip. They had to, instead of being receiving hospitals, they were the sending hospitals. And now our hospitals that were out in the community, out east in Long Island and in the upper Westchester area, those typically are our sending hospitals that send to the tertiary area. But now these sending hospitals became receiving hospitals. And you can only imagine the challenges that these hospitals faced. One, they don't have as many subspecialties as the tertiary hospitals do. Two, they don't have the sophisticated bedboard, often the software that the tertiary hospitals have. They don't have the flexible staffing as much as the tertiary hospitals have. So it was a struggle for these, sending these hospitals to become receiving hospitals, but they did it with open arms and they were very willing to accept these patients despite all the challenges. The other thing we focused on was not transferring these patients like everybody usually does to the emergency room. We really focused on being able to, when we were ready to transfer a patient to an actual inpatient bed. That was huge for us, and that was very important to us, to be able to do that. Our goal was really for no patient to ever be without a ventilator or without care. And that's why load balancing was very important to us. But again, we had to develop processes to do that. We had to develop ability to do that so that we could see patients throughout our whole system. And we're going to discuss that a little bit further.
So there we were. We had 8 hospitals that were bursting at the seams. Everything was failing. All these outlying facilities that had tons of space. Now we had an executive order saying, yep, you can pick up people and move them whether they like it or not. So all we had to do then was find the patients and move them. And that was when we realized that we had absolutely no visibility into any of these hospitals at all. So the hospitals that would need to find the patients to know which ones were able to be moved were the ones that were so overwhelmed, there was nobody on the ground to be able to go look for people that could move. So even though we had empty beds waiting and ambulances to move people, we didn't have anyone to pick the people. So we rapidly developed some customized software that pulled feeds off of all of our hospitals, all 23 of our facilities, and allowed us to look in real time to look into all of the units of any of the hospitals that we were trying to evacuate. And we were pulling real-time data about the patients, their demographics, their vital signs, their oxygen requirements, without having to open every single chart and look at everything. These useful data points were sort of plucked out and then put together in one place. So a person that was on the ground in the overwhelmed hospital had a chase list that was already sorted and put together to help them in the least amount of time, hopefully pick the patients that were able to be moved and to make sure that they actually, when they eyeballed them, were as okay to move as the software thought they were. Meanwhile, all the hospitals in the periphery were putting in their bed availability onto sort of the right side of this screen. And then at our centralized transfer center where our ambulances are dispatched, they sort of had a bird's eye view of the patients that were selected by the software, approved by the on-site staff, and then they matched them with the available beds at the different facilities based on what they were able to accept, and then coordinated the entire process from a centralized location. And so this really dramatically changed how we went about our transferring. There was no more calling from the sending facility to a transfer center, getting transferred to a receiving center. Now it was actually the transfer center saying, we want these 7 patients, we're coming to get them, unless you say stop. And it just really switched everything on its head. At the next slide.
And for full disclosure, none of these names are accurate.
This is all made up.
They're made up names. Okay.
So how did it work? Well, in wave 1, that ridiculous giant spike, when we first discovered how to do this load balancing, the entire first spike, which lasted around 30 days, we moved 810 patients between acute care facilities. And at that time, it was really inpatient bed to inpatient bed, ER to inpatient bed. Once in a while, we even did inpatient bed to ER when there wasn't any other opportunities, but really we tried to keep people from just essentially getting dumped in the ER of any of the receiving hospitals. So we knew that it worked, and we were revved up and totally ready to go for wave 2. Now, wave 2 was a longer, slower wave. You see it's actually around 4 months on this list here under wave 2. And in that 4 months, not only did we move around the same number, about 900 patients between our acute care centers, but we learned, as I'm sure many of you know, one of the biggest problems with COVID patients is getting them out of the hospital because there's often nowhere to send them. So we had 2 subacute rehab facilities that we redesignated as COVID-only facilities, moved the non-COVID patients out to other facilities, and then we were able to actually move patients from our acute care space into our COVID-only subacute rehabs. And you can see that between the 2, we moved around 600 patients in that capacity. We also realized in wave 1 that we had this problem with our psych facilities. The moment one person was COVID positive in the psych facilities, craziness ensued. So we set aside a unit at one of our psych facilities only for COVID positive patients, and then moved all of our COVID positive psychiatric patients from all through our system to that one unit, and that was 45 patients. And even to this day, although this graph ended in around April, we are still moving 5 or 10 patients a day for a variety of reasons in this sort of load balancing fashion. So grand total, about 2,500 patients went through this process in our 23 hospitals. Next slide.
And I just want to add one other important fact is that when you're looking at that map, a lot of our hospitals on the map look like they're close to one another, and they might be 15 miles away. But in New York City or around the New York City area, if you try to sometimes commute 15 miles, it could easily take you 2 hours to get there. And that is one of the issues that we had in New York is, the commuting time. And we were worried about putting patients in an ambulance and then decompensating. As many of you know, patients with COVID often decompensated pretty quickly. So that was also one of our concerns. And then I would just also add that one of the issues we struggled with in New York City is, even though Eric mentioned, tents, and we did put up tents, but we are landlocked in New York City. It's not like we have that much area to just throw up a tent anywhere. It has to be very, very strategic. And those are 2 of the difficulties I think that we faced in New York City. But one of the things is, again, like I said earlier, we didn't move just patients. We moved a lot of different items. And, one of the items we moved, and I can remember early on, was, when remdesivir came out, the government basically was assigned to allocating the remdesivir to the hospitals, and they would tell us which hospital it was going to and how many vials we had. So when remdesivir first came out, we had 23 facilities, and only 4 facilities received the first allocations of remdesivir. Well, we thought that was a little bit unethical, and we sort of went against the state, although we did, kind of let the state know we were going to do this because we didn't really want to get in trouble. But we did tell them that, we were going to take all 4 hospitals' allocations, put it in a central region, and then we would then subdivide it between our hospitals, because again, we felt that we needed to be fair, transparent, and equitable to all patients. And so we came up with prioritization lists of the patients that we thought that would benefit the most from remdesivir. And then we distributed it based on, this load balancing, instead of the government really telling us how many, vials could go to each hospital. Prior to COVID, our emergency management system really only had about 36 biomedical devices that they, kept in a central location, for deployment. If one broke at another hospital, or if one had to go for service, people would call the central location, and you were able to get a device. But during COVID, we added an additional 5,500 devices in a matter of 2 months, which included an extra 668 ventilators and 38 BiPAP machines. And remember that all of these devices need to still be procured. They need to be assembled, and then they need to be inspected. And, there was plenty of shortages out there. So this was a really big, challenge for us to get this equipment. We essentially doubled the number of respiratory support machines that we had within our, system. And we also found ways of converting our BiPAP machines, not only to be ventilators, but we also found ways for them to become delivery systems for high flow oxygen, which was really, important more in the second wave, because in the first wave, we kind of all thought everybody needs to be intubated because everyone was afraid of aerosolizing procedures. And so for the first wave, we were converting our BiPAP machines for ventilators. And during the second wave, we were converting them to high flow, oxygen delivery. We were also trying to come up with creative ways of dealing with equipment shortages. Things like we used our 3D printing to make splitters because we were worried about putting patients, not having enough ventilators for all our patients. So we were talking about coming up with protocols for putting 2 patients on a ventilator. We also had shortages with tubing for the ventilators. We had to send one of our guys to Home Depot to buy hose in order to have enough hosing for ventilators. So we came up with very creative ideas during this time. And we also had to build a whole warehouse and manage a whole warehouse to keep all of this equipment. This is just a couple of pictures from one of the warehouses where we keep a lot of our items. And you can see there one of our techs using the hose that they bought at Home Depot and trying to see in case we really had to go to crisis mode, could we use these items?
So we learned a lot of lessons in wave 1, and we tried to distill just a couple of our favorite lessons onto one slide. So the first was that we realized that we had a long way to go in the tech department when it came to 30,000 foot view of our system, and in many of our hospitals, even a 10,000 foot view of a hospital. So we've really done a lot since then to improve our use of real-time data, and not just for this purpose, but for other operational and clinical purposes. Our supply chain also dramatically improved their reliance on tech to be able to track all these things. So we learned the hard way, as I'm sure many people did, not to rely on anyone else to come save the day. In particular, we had a relatively well publicized issues with the USS Comfort and the Javits Center being a lot of press and not a lot of help, which is a whole story into of itself. We learned that you can actually freeze your oxygen system in your hospital if you use too much oxygen all at once. They actually freeze, which is news to me. We decided to, as I said earlier, to change 2 of our subacute rehab facilities to COVID-only facilities. And if there were to be another wave, we would certainly do that again. We did the reverse. We set aside one of our smaller hospitals as a COVID-contained hospital, so essentially a COVID-free hospital. And we did that specifically for surgical services, so that by referring all of our surgical cases into that centralized place, we could keep our surgical services open as long as possible. We also participated in a Big Brother, Big Sister program, we affectionately called it, where several of the local hospitals that were not in systems, we sort of adopted them and helped them with their emergency management, supplies, PPE, staffing, et cetera. And then we have, as you just saw in the prior slide, we've maintained all of the equipment that we mentioned earlier, and that required not just 1, but 2 brand new warehouses. So never thought we'd ever have to do that. Annabella?
Okay, thank you. And now we were going to hand it off to Dr. Romney and Dr. Sharma.
Thanks, Annabella. So I'm going to pivot a little bit and spend some time talking about the psychological impact that the COVID pandemic had on our frontline staff. In particular, I think it's important to highlight how that impact changed over time and over the course of the 2 surges we experienced in New York City. I'm going to share a bit about wave 1, and then Dr. Sharma is going to talk about how things were in October and going forward. I think as a former runner, in my opinion, a good analogy for what we experienced would be a relay race that seemed to transition from a sprint to what at times felt like a never-ending marathon. If you can imagine what the psychological and emotional state of runners are in those various settings. In the first surge, we were at the epicenter. Our institution cared for the first COVID confirmed patient in New York City. From that day forward, things ramped up really quickly. I think for those of us in emergency medicine, it was a really invigorating time because it felt like the type of crisis that our training had prepared us to respond to. Our frontline teams and department leadership worked around the clock, developing clinical guidelines similar to the ones Eric talked about, and innovative care delivery models, and securing resources to help support the team. I don't think our sense of purpose could have been any higher. Something that was unique about Wave 1 is what seemed to be an abundance of support at the system level, at the department level, even the community level, both local and across the country. It seemed that everyone was focused on New York City and focused on trying to figure out how to help us through this wave. The support from our fellow New Yorkers across the boroughs was really strong. You know, New Yorkers are not known to be particularly friendly people, but yet for weeks at 7 p.m. every evening, for 2 uninterrupted minutes, people across the city stopped whatever they were doing to give thanks and show gratitude for frontline workers. They opened windows, they came out on rooftops, they were banging pots and pans and honking their horns as just recognition and appreciation for people they knew were risking their lives fighting against this pandemic. I have to say, I had the pleasure of going in on a couple of night shifts and experiencing that cheering, and it was truly uplifting. It gave us the push that we needed to keep going. Similar to the impact that you can imagine you could hear, similar to the impact that you would imagine cheering would have at a race. Next slide. The support we received at the institutional level was also pretty good. At almost every entry and exit of our hospital, non-clinical staff came together to create chalk art with words of encouragement like the ones you see here. Unfortunately, I couldn't find a picture of my favorite one, but it read, "If you're just arriving, thank you for what you're about to do. And if you're leaving, thank you for what you've done." The hospital provided free meals 3 times a day. There was also free parking for employees in the lot. At the department level, our administrative staff turned our conference room into a wellness lounge where they replenished snacks and arranged hot meals that had been donated for each shift, just giving people a place to kind of take a break, catch their breath while working clinically. We, as the leadership in the department, organized a wellness event called Haircuts for Healthcare Heroes, where the stylists you see pictured here volunteered his time to provide free haircuts to our frontline staff while they were on clinical shift. They came in rotation. Next slide. In this slide is a mural that was created by one of our ED teams, but there were multiple that had the opportunity to participate, that was done in conjunction with one of the art therapists in the hospital. She brought all of her art supplies and a canvas to the break rooms where she engaged and encouraged the frontline staff to put into art what they were feeling. You can see there's a lot represented here in the imagery, but the staff expressed how cathartic that experience had been. In the department, we also partnered with our colleagues in psychiatry to offer each faculty member a 30-minute counseling session. Rather than having people opt in, we actually scheduled them for 30 minutes based on their clinical schedule, and they had to opt out if they didn't want to participate. And for many, it was the first time that they'd spoken with a therapist, and for some, it went on to become a longer-term relationship. These were just some of the ways that mental health was supported during the first wave. When reflecting about that time with members of our team, people of course talk about how difficult it was to see so much death and navigate managing an illness we knew nothing about. However, sentiments related to wellness were very similar. I think during wave 1, people felt appreciated and they felt supported. And they say it was that support that really helped get them through that first wave. I want to hand off now to Dr. Sharma so he can talk a little bit about what the experience was during the second wave.
All right, thank you, Dr. Romney. So not to say the support went away, but it wasn't at the same level, we'll say, after the first few months. If you've seen all the slides up to now, you realize that we had a surge. Our initial surge was not as high, even in number of cases per day, as our second surge. And in between those 2 surges, you saw depleted ED volumes. While nobody discussed what was going on with staffing, I can say that while our calling was great, our feelings about the future of emergency medicine was coming into question at that time, and about job security as well too. A lot of those things weren't discussed because we all assumed ED volumes would return. But people internally were feeling what's going to happen if volumes don't return? Am I going to have a job? In addition to that, as a second wave was kicking in and ED volumes were, we won't say surging, but at least ED admissions and ED holds, and the overall conditions in the emergency departments were becoming challenging again. We had staff that were coming in every day when everyone saw, Time Life magazine about all the byproducts of wearing masks and N95s every single day at work for 12 to 14 hours. All those conversations had gone, yet that was still the protocol. So work in the ED was challenging. Admissions and boarding was challenging. The daily deliveries of food, the clapping, the daily recognition did not exist anymore after the first, I would say, 4 to 5 to 6 months. People had shifted into moving on with life to a certain extent, whether it be we have to think about the next residency class recruitment if you're in an academic setting. We have to return to, because a lot of the other specialties were also having, we'll say, an emotional impact. Things I heard were surgeons who were not operating for 6 months were getting depressed because that's what they trained for. Pediatric emergency physicians were taking care of adults in many systems. Once again, not what they trained for, not what they basically got into this career for. So everyone was under a tremendous amount of stress, and in many ways, the attitude became that we have to move on. It's been 6 months already. So while the support was there, it wasn't as prevalent as it was in the first. And the word heroes, I don't remember hearing after the first 6 months either. The healthcare heroes theme had moved on to everyone is doing their jobs. We realized some of these things late. I'll be first to admit. If anyone can imagine what it feels like to go into emergency medicine knowing as a resident that when you come out, you'll have multiple jobs available to you and many not be able to find a job till 4 or 5 months before you're going to be starting about that impact. While we had done a lot of load balancing in terms of we referred patients to other locations, we did telehealth, it was the opposite in the ending where because ED volumes are lower, nurses who are regularly coming to the ER were deployed to other units where they were needed, inpatient units. Once again, a very stressful time where support is available, but just not upfront to you every single day when you walk into work. So like I said, when it becomes a marathon, if you've ever seen the crowds at the beginning and the end of a marathon are usually very, very big. And they kind of tail off if you ever watched the New York City Marathon into different areas. And I think many people who were frontline workers felt like while they were in the middle of this, there was no light at the end of the tunnel. There was no daily support. There was an angst about, am I going to have a job when this ends? What is the future of emergency medicine and volumes? And honestly, residents who didn't know if the last 7 years of their life were spent leading into a career where they may or may not be able to find jobs. So it was an extremely challenging time, not just for physicians, nurses, other specialties also. While we feel like we're at the other side of the curve right now, nobody feels COVID has moved on, and everyone still is, I will say, post-traumatic stress, waiting for the third wave to occur again. So I'll turn it over to Dr. Kwan again.
Thank you, everybody. That was a really incredible. And one of the, if you could stop on sharing the slides, one of the things I want to do, especially since it's a small group, is to have everybody really, if you can, come on camera. Because I think, just despite the fact that we have panelists who are talking about this, I think everybody experienced it in a different way and is an expert in your own right. So I'd rather make this more of a group discussion and include all the guests as well. Thank you. So welcome. One of the questions I want to, well, actually, I'm going to open it up to the audience and see if you have any questions. Otherwise, I could throw out questions endlessly.
I have one thing. First of all, I thought that was awesome. I was an ER tech last year. I'm a first year med student this year. So at the beginning of COVID in Seattle, and it was a lot different over there. And we heard rumors about how things were in New York, but to actually have a talk on it was phenomenal. I kind of wanted to ask a question to Dr. Sharma and Romney about the COVID fatigue. I know you guys addressed, you guys would, move the staff lounge and stuff like that and make it kind of a, I can't remember if you said mental health space or something, but was COVID fatigue ever like really addressed, or was it just something that people kind of knew was around but not addressed at like a management level for all the staff?
Okay, so Marie, go ahead first.
No, I was going to say, you know, I think we did the best that we could with what we had. One of the things that happened, and I kind of was going to include it, not include it, you know, there was a lot of enthusiasm to come and help from around the country. But at our organization, particularly for the physicians, the help arrived a little later than we would have liked. And so what we did to leverage that, because we had those resources, was take people off of shift and have that help work their shift. So even though we were on the other side of the wave, it was an attempt to give a reprieve. The other thing that we did was, in addition to those 30-minute mental health appointments, was again working with our colleagues in psychiatry. We had an open forum, started out 3 times a week, then 2 times, then once, which was just an open Zoom with a psychiatrist on as a moderator, where people could come without scheduling an appointment if they wanted to kind of talk about whatever it was that they were feeling. So whether or not we were successful in addressing it is not really something I can answer, but we did try.
That's awesome. Thank you.
I would just also say there's 2 types of fatigue. There's this fatigue that we all emergency physicians are just used to having during 12-hour shifts, feeling like we came to work with a ton of energy and just can't wait till that 12th hour comes. So I feel like we did address it a little bit within our institution and I've heard in other institutions also for flexibility to make shifts shorter, to make them 8 hours, because wearing a mask, seeing patients, gowning, degowning is physically stressful. Forget about the emotional part. So we transitioned over the last year to pretty much every shift being an 8-hour shift. We did that mindfully, knowing that it's better for providers. In terms of the other fatigue of just always seeing death in the first wave, and then the second wave, seeing people who you can't understand are this sick and why they're sick. I think we did our best to try to address it by being present and talking with our colleagues. Always making ourselves available to listen to them, whether it be honestly for a tearful session or just for a questioning session. But I feel like, of course, we could have all addressed it better. And maybe with the next pandemic or the next epidemic, we will be better at it.
I also just want to say thank you all for what you do. This is, yeah, New York, I heard, got hit bad. I wasn't there during it at all. But yeah, thank you for this talk. And this was awesome.
Oh, thank you. So nice. I want to open it up to more questions or comments or whatever you want alone, your own experiences.
I think the only comment I'll add to what was just previously said was that even when you consciously try to get your teammates to take a break, there was also this sort of feeling with individuals like, well, what does that mean exactly? Like, it's not like I could go on vacation. It's not like I can go to a movie or a concert. And so people were kind of still at home, and then they struggled with, my colleagues are fighting the war and now I'm kind of home, even if it's for just a day. We were very conflicted. I think people were very conflicted with their emotions. And I think that's something that's sometimes hard to address. So even though you could throw a lot of resources at physicians and in our system, we had tons of different types of wellness activities and hotlines and connect the docs and dinners and like where they did remote dinners. But it's still, when you're in it, there's this sort of, guilt that sometimes we all feel when there's a pandemic going on. And, it's hard to let go, I think, during that period. And I think that's the problem with New York, is that people have been feeling this way for a year. And so there's this just chronic fatigue. And hopefully now that the summer is coming and the numbers are down and traveling is, opening up a little bit, people will actually maybe really have a little bit of time off.
if most
Because there's a
people,
lot of people that have not traveled or done anything for over a year in New
I'm
York.
sure in most of your departments, you know, the mood within the department is always at the highest for the week after a graduation party, a Christmas party, because it's the place that people de-stress and kind of bond again, and there was none of that.
I'm interested, you know, for the group, and Maria, I loved hearing about how you converted the room to like a wellness area. In hindsight, you know, that's fantastic. What did other people do, and are you still doing it? Because even sitting here, I'm like, God, I feel exhausted, you know, and I'm sure others do.
We converted our classrooms because there was no more in-person resident conference to I mean, it's a very serene yoga-ish kind of environment that anyone can go to in the hospital during pretty much any hours. So the thought existed in many hospitals that people need a place to walk away from what they're doing.
This is Nancy. I agree. I think, we created a couple of Zen rooms in our emergency department where people could get away to, essentially like within the first week of the pandemic, we asked for picnic tables outside as the weather got warmer, and they, within like 6 hours, they had them outside, and we encourage people to take breaks. I think I see one of my co-attendings here, Dr. Ciano, I think we're trying to look out for the residents and really encourage them to take breaks during their shifts. Joey, I don't know if there's anything that you want to add. But I think a real focus on wellness, and maybe a question I'm going to throw back to everybody is, I think we all know doctors are a tough bunch, especially emergency medicine doctors, and a lot of people won't acknowledge that they're not, doing well or feeling well, no matter, what you put in front of them, whether it's, opportunity to meet with psychiatrists or group discussions. So what are ways you think we can sort of break down those walls of that, like, I'm tough, I can get through anything, I can work like crazy, but know that people that we wouldn't never expect are not well, have not been well. So I think we've had difficulty at our own site. We've offered that up, that opportunity, and nobody actually like grabbed on, but I know that people are probably not, where they should be mentally after COVID. So I've opened that up as a discussion point for everybody.
I think one of the things is what Dr. Romney said, you kind of, you bring it to them and don't make it, yes, people want to have choices, but sometimes you have to just do it, whether it's you bring somebody into faculty meeting and everyone has to listen to it, or whether you sign everybody up and then you have to opt out. Because sometimes, to your point, people may not realize they actually need it until they're doing it, or sometimes they feel better after they've done it. So,
yeah, we had sessions with psychiatrists for attendings, for residents, for nurses, for different groups. And only the Jonathan, you were at them, only the attendings really spoke. The residents were absolutely quiet, stoic, and said nothing. So even the psychiatrist was like, I'm going to continue these sessions, but no one's sharing. Because it was more about, I just want to get through 3 years. I just want to get through this year. And it was challenging.
And I know are we out of time?
They said we could go longer, right, Namita?
No, yeah, you've got a couple more minutes. You started at the 15 past the hour, so I'd say you got a couple more minutes. I actually just wanted to make a comment to add on that, because I think there is a cultural component in emergency medicine in the United States that really the COVID pandemic highlighted an opportunity for change, but I don't think it's going to change overnight. And that creating a culture of acceptance is probably where we need to go. I trained in emergency medicine in Ireland first before coming back to the US. And one of the things that when I was an emergency physician in Ireland, we did 12-hour shifts, but it was very important for me to ensure that myself and my junior residents would always take at least a 5-minute break, even if it was really busy. And that was the accepted culture. We had our tea room right next to the department, and it was okay to go in, get a cup of tea in Ireland, not coffee, grab a sandwich, and then come back. When it was really busy, I would say, you got 5 minutes, but go take the 5 minutes. When I started back in the United States and I had to redo my residency, the first thing that I was struck with was when I said I'm going to take a 5-minute break, everyone looked at me like I was crazy. and I noticed that was the first cultural difference I noticed. And so moving forward, I think this provides us an opportunity with shifting our culture of emergency medicine here, but it takes creating an environment of acceptance. So not only saying, go take that break, showing as leaders in the departments, taking the break yourself to show that it's an accepted culture within emergency medicine as a specialty.
Yeah, and I've heard of some places that even like sort of rotate like lunch breaks for people at different, during different times, like team A goes, team B goes to their break. I do want to open this up to the people who are emergency medicine leaders. You mentioned a lot of like wonderful things that happened, like supportive things that happened. But what was the hardest part of what you went through as a leader during COVID, and what have you gained from that you've changed in your practice now as a leader on the other side of the second wave?
Can I answer that question with a totally separate question?
Sure.
But I think I just want to think.
I love a question with a question.
I'm not answering your question, but I think I do want to touch base on something I think is actually important that came out of this. There's a saying, don't let a crisis go to waste. And one of the things that I think has been very both useful and potentially very, it may change things for us in the future, is that kind of as the first wave was finishing, a group got together, which many of the people on this call are on. And it really was the leaders of emergency medicine from across New York City, both New York and the boroughs, Manhattan and the boroughs. And it has met probably 30 times. And it has really been focused on what are the challenges across the city? What are the challenges that are unique to emergency medicine? How can we talk as a unified voice and get the stakeholders involved? And how to do it in a way that where our institutions may feel, I don't say threatened, but it may not necessarily be in the institutional interest, but it's in the city interest and in the patient interest. And how do we press that to our advantage coming from a unified voice? And so we've had meetings through this kind of group that have been both, within ourselves. We've had people from the Department of Health involved. We've had the Greater New York Health Association involved. There was a recent one about how can we bring vaccines into the emergency department in New York City, and what are the ways to do that effectively? We've talked about load balancing across the city, problems with diversion. And so I think that one of the things that I think has been very useful is for us to see as leaders of departments that the problems are the same, and the solutions are not something that we necessarily can do in our own individual institution, but it revolves both banding together, forcing changes in the laws and the regulations, and trying to show that really changes that people don't necessarily want for their own individual institutions, but are helpful overall. And so I really, have a lot of sense that this will move things forward in some way, shape, or form.
Yeah, Eric, I really want to jump on that because it was really important from the institutional level to band together, and especially when we wanted the state to move on things. And I remember the running joke at our institution, it was, let's get the 5 families together. And if anybody lives in New York, the 5 families are the 5 healthcare systems that run New York State, essentially, or especially New York City area. And so we would reach out to our counterparts at the other healthcare system, and that's how we would get the state often to move on certain decisions that they would make, is that we would get the 5 families together and work with Greater New York, who's our healthcare organization that kind of oversees hospital associations. But I want to, second what Eric said, that was one of the biggest lessons learned and things that we will continue to do forward.
I think it's funny that you mentioned all this, like the people that we have together on this didactic, we all know each other and are friends with each other. But despite that, in the sort of height of the pandemic, obviously nobody had time. So it's kind of like, a lot of it would be quick reach outs like, hey, how's it going over there, with the text message without having the time to talk. So this is actually probably the lengthiest we've had the opportunity to speak with each other. So despite the fact that I'm on the panel, I'm getting a lot out of it because we sort of did a little preparation for this, but we really never went through kind of everything that we're going to say. And it's kind of like nice to be able just to hear what everybody's insights are fresh for extended period of time, instead of like a quick text message like, hey, I gotta go because I gotta go take care of COVID patients. So, and I think to Eric's point, I think maybe historically pre-COVID, sometimes health systems are like, well, I don't want to share that with you because you might steal that from me. But that's not the point of this. And with what Eric did with the EM practice and just putting it out there, that's I think what we've gotten to today, that if it's the best for your staff and for your patient, then we and your patients, then we need to share. So I wanted to open it more up to the audience. Did you have any other questions or thoughts? We've been talking a lot. I see Dr. Barron, Dr. Siegel.
One thing I will say, to go off of what Namita said about changing the culture in terms of breaks. I know there was a lot of talk about wellness. I'm close with all of my colleagues. I'm an ER doctor at Northwell. But one practice for myself that I've changed, and I've also noticed that other attendings do this as well, when they come on to shift at sign out, I notice more now, not always, but I feel definitely compared to pre-COVID, there's more of a shift of people asking authentically, like, how are you? And the responses seem to be different. And also to residents. And I've tried to adapt that practice a little bit more. And I've at times been a little bit shocked at some of the responses, not being super positive. People are having a hard time and they're being more open about it. But I think that's a really good thing, that it's okay to not be okay. And it's okay to ask people how they're doing, even though there's craziness happening in the background. Like it's okay to take a couple minutes, when you're already talking about, sign out and you have that minutes, you're sitting down at a computer to actually ask about how other people are doing.
I think it's a really great point. Back to what I think Eric said, don't let a crisis go without gain. I don't know, I'm botching that paraphrase, but we're going to come out of this now, and the mandates yesterday, mask off, and volumes come back, and it's what we went through hasn't left us, and so those conversations are still important. And I think we're the ones that are going to be advocating for what it is that we need from a wellness perspective, from a mental health perspective, and in much of the same way that we look back in hindsight now and say, well, this is what we did during the first phase, this is what we were doing during the second phase. What's the opportunity that we need to recognize right now as we come out of it? It's spring, we're moving towards the summer. Last summer didn't really feel relaxing, even though it was supposed to. It was, what just happened. So now we're coming out of it again, and it's going to be different this time. And I think you have to double down on the mental health front and make sure that it continues to be okay to say, I'm not right now. I don't feel okay. And I was on a call 2 nights ago, and the person that I was speaking to started asking me questions, and I didn't understand why we were starting out that way. And he said, I'm doing a wellness check right now, just so you know. And I said, okay, thanks. So it's important to keep that up.
I think what we found, talking about the support, is it's really not a one size fits all. I mean, you talk about people that weren't participating at the big sessions. You know what? There were times the last thing I wanted to do was sit around and talk to my colleagues. I just wanted like some quiet. And we initiated throughout our system a kind of a battle buddy sort of system for people who identified, and it could have just been your friend, whoever it was, someone you could just call and say, you know what, today it was really awful. Or that you would check in on them if you didn't hear something. And for some people, that was all they needed. So you just have to kind of be liberal about what people need and just, give them options.
I agree.
Yeah, I think you're absolutely right. There's people who are very, very different, and some people need a lot, and some people don't want a lot. I think that's really important.
Well, I had a couple thoughts that we didn't mention yet. What was unique about COVID and what we went through? And what was unique to me was the lack of visitation for patients. Bad things, being critical and expiring and whatnot. In this instance, we had to see them do it alone, or holding up a phone and having those horrible conversations with family and holding up the phone for FaceTime. And learning from this and not letting crisis go to waste, I think we should consider what we're going to do for visitation in a future event. Was it right to completely shut off hospitals for months, 6 months, 9 months, and nursing homes for that amount of time? There was an impact on both the providers and definitely on the patients to have to go through that. Just putting it out there for as what we learned from this one. The second stress was, we're used to stressful shifts in the ED. We've never been, what can I say, bringing the virus home. A lot of us sent our families away from us. I sent my wife and my kids away for 5 weeks and lived by myself. And I think that was very common. So that's just something else that was unique with COVID. That we had to ask ourselves, like, are you okay? And also, what are you doing with the family, and how do you feel? Are they safe? It was just onto those two topics that were unique to COVID and hadn't been touched on yet.
I think what's clear here is that there is a lot that needs to be talked about as we move into this post-pandemic era. The robustness of this conversation clearly tells me that there's a lot of value in sharing these concepts. This has been an amazing discussion, amazing panel, robust conversations. Unfortunately, I do have to end the session now and wrap it up. But I'd like to thank you all for sharing your experiences. I felt a definite empathy because I'm based in Detroit. Our curves very much mirrored yours. So like you said, there's a little bit PTSD coming back, and there's definitely a lot more to talk about in the future. Thank you so much and enjoy the rest of your day.
Thank you, everybody, for joining.
Thank you all.